Yeah, I think we can start now. While waiting for other speaker. Good morning, good evening, and good afternoon to all. This is our second edition of ACNS EANS skull-based section on our webinar. And today we have a sixth speaker today. Let me introduce our first speaker, who I'm sorry because he's actually in the airport, unable to join.
Sorry.
Probably we skip first. Ben, try to download again. Can we move on to the next speaker? It will give me a great honor to call upon.
I think so.
Yeah, Professor 𝑇𝑎𝑘𝑒𝑜 𝐺𝑜𝑡𝑜, who is a professor and chairman of the Osaka Metropolitan University Graduate School of Medicine, Osaka, Japan. His topic for today's presentation is on endoscopic keyhole anterior petrosal approach for the lesion around petrous apex. Let's welcome Professor 𝐺𝑜𝑡𝑜.
Okay, so I will share my presentation. Okay, can you see my slide? Okay.
Yes. Yes.
Okay. So today my topic is endoscopic keyhole anterior transpetrosal approach to the region around petrous apex. At once, I will introduce our institute. Our university, Osaka Metropolitan University, is one of the largest skull-based centers in Japan. So our old mentor, Professor Hakuba, started the combined transpetrosal approach for the region around the petrous apex. He already published the combined petrosal approach in 1980s. It was very useful procedure, and he mentioned that the key step of this approach is the wide opening of the Meckel cave and expose the trigeminal nerve from Meckel cave to brainstem is key point of this approach. And we can access the petroclival region from the lateral side. This is a tip of this approach. Recently, endoscope can offer a very good surgical view in deep-seated area. So now some petrous apex region can be safely resected. Pure endoscopic keyhole anterior transpetrosal approach. I will show our surgical technique at first. We put the skin incision around the temporal base and put the craniotomy with a size about 3 centimeters. And then we insert the endoscope to the subdural space. This is a trigeminal nerve, covers the dura mater. And we can identify the GSPN using the facial nerve stimulator. After identify the GSPN, we cut the dura mater medial side of the GSPN to expose the Kawashi's triangle. And then we drill out the Kawashi's triangle, and after open the Meckel cave, we can expose the trigeminal nerve from the Meckel cave to brainstem. So this surgical view is completely similar of the microscopic anterior transpetrosal approach. I will show our surgical video. This patient referred to us with a chief complaint of the uncontrollable trigeminal neuralgia after the gamma knife, but the lesion was very small. So we choose a less invasive procedure to the lesion. I will show our surgical video. At first, we put the craniotomy with just 3 centimeters, and then we insert the endoscope. We identify the GSPN, and this is the middle fossa. I cut the dura medial side of the GSPN to expose the Kawashi's triangle. This is a Kawashi's triangle. I carefully drill out the petrous apex to detach the tumor and also to cut the SPS. After completely drill out the bony structure, all attachment was coagulate and detached. So we can safely resect it out the tumor. We cut the tentorium to confirm the fourth nerve, medial side of the tumor like this. And then we dissect the tumor from the inferior surface of the tentorium. And finally, all tumor was resected out. In this case, tumor compressed the SCA, and SCA compressed the trigeminal nerve. So I mobilize the SCA of the trigeminal nerve like this. Now we confirm the old SCA away from the trigeminal nerve. If we insert the endoscope more deep side, we can confirm the sixth nerve and seventh and eighth nerve. So this view is very similar of that of microscopic anterior transpetrosal approach. Postoperatively, the anterior petrous apex was nicely drilled out, and the tumor was resected out through the keyhole. This is another case of the trigeminal schwannoma, occupies a Meckel cave, CP angle, and infratemporal fossa. I also apply the endoscope to this region. The size of craniotomy is the same. It's about 3.5 centimeter. And then I identify the GSPN and then expose the petrous apex. After drill out the petrous apex, I open the Meckel cave. This is a trigeminal schwannoma, so we preserve the normal nerve fiber and continue the subcapsular dissection. Now we reach the infratemporal fossa like this, and also we can observe the posterior fossa like this. So we confirm all tumor was resected out through the narrow keyhole. Tumor in the Meckel cave, posterior fossa, and the infratemporal fossa was nicely resected out. This is another case of the relatively large trigeminal schwannoma, but I use the same technique. The size of craniotomy is also 3 centimeters, and then insert the endoscope. This case, at first we open the Meckel cave. This is a normal trigeminal fiber, and this is a tumor. At first, I dissect the normal fiber and then go into the tumor. After go into the tumor, we continue the subcapsular resection. At first, we carefully dissect the tumor around the Meckel cave, and then we additionally drill out the petrous apex to go to the posterior fossa. After drill out the petrous apex, we completely open the Meckel cave to go to the posterior fossa. And then we continue the internal debulking and preserve the membrane. So now we completely perform the subcapsular dissection. Trigeminal fiber preserved, and then all tumor was nicely resected. This is another case of the chondrosarcoma associated with osteogenesis imperfecta. For her vaginal invagination, the angle of the tentorial edge was very steep. But through the endoscope, we can observe the superior part of the tumor through the keyhole. This is a surgical view. We can observe the superior margin of the tumor. This is a fourth nerve, and this is a trigeminal nerve. Endoscope can offer very good clear view around the CP angle, medial side of the trigeminal nerve. So we carefully dissect the tumor from the brainstem, and all tumor was nicely resected out. Tumor was safely resected out. This is another case of the petroclival meningioma, but patient age was a bit old. So we selected also less invasive procedure, keyhole anterior transpetrosal approach. The size of craniotomy also same, and then we gently retract the temporal lobe and identify the GSPN. I cut the dura medial side of the GSPN to expose the Kawasaki triangle and also open the Meckel cave. And then I carefully drill out the Kawasaki triangle and then open the Becquerel curve. This is a medial tentorial edge. I cut the tentorium to confirm the SCA and force nerve. Now I completely cut the tentorium, and this is a force nerve, and this is a SCA. Endoscope can offer a very good view. This is the medial side of the trigeminal nerve. So this is the main attachment of the tumor. I completely detach the tumor through the endoscope. After detach the tumor, we not encounter the bleeding. So dissection of the critical structure or brainstem is easy. Now we reach the upper margin of the tumor, very close to the third nerve. I decompress the tumor from the third nerve. This is the tentorial edge. So we resected out most part of the tumor very safely. This is a post-op MRI. Tumor was resected out through the keyhole. This is another case of the petrous apex meningioma, nicely resected. And this is a trigeminal schwannoma, also very useful. This is also trigeminal schwannoma. We can resect some temporal keyhole anterior transpetrosal approach. So today, we can present our endoscopic keyhole anterior transpetrosal approach. Endoscope can offer very clear view around the petrous apex. In addition, the proximal side of the endoscope is very safe, so we can perform the smooth manipulation of the tumor. We published this technique to JNS this year, so if you have some interest to this technique, please check this paper. Thank you for attention.
Thank you, Professor Goto. It was an excellent talk. I was very interested to hear your talk. I saw your paper in JNS. I was very impressed. Very large experience. Congratulations for this new approach that you are showing us. I just had one or two questions. How much of your petrosectomy is done extradurally, or is all of it done intradurally, your petrosectomy, the removal of the petrous apex?
Thank you. In our case, most petrosectomy was done by the subdural approach. So I just expose the Kawase triangle through the subdural space. This procedure minimizes the epidural, the dural dissection. It minimizes the venous bleeding around the middle fossa.
Okay. Well, just one more question. Your GSPN is identified from the intradural compartment, or do you see it in the extradural compartment first?
Thank you. We usually identify the GSPN through the subdural space. I stimulate the middle fossa dura using the facial nerve stimulator. We can get the response, so we can identify the cause of GSPN.
Congratulations on this new approach. I'm quite impressed with your results.
Thank you.
Any other questions?
May I ask one question, Professor Goto?
Yes.
Yeah, I wonder because regarding temporal approach extradurally, how do you ensure, because I saw your scan all are good without any temporal brain injury. I think the risks are always there. How do you assure that they will not have any contusion or temporal lobe, Professor? Thank you.
Thank you. To prevent the temporal contusion, I usually insert the spinal lumbar drain before retract the temporal base, and also just put the cottonoid and gently just mobilize the temporal bone. So we not use a spatula during the surgery. And we check the always venous structure around the temporal base. But in our experience, anterior part of the temporal base, there is no large cortical vein. So we can perform this subdural procedure. Thank you. Good question.
Just one more question, Professor. Do you routinely do a extradural ultrasound to check before you close the case? Ultrasound to check any hematoma for any hematoma? Ultrasound.
No. Just
No.
we find out the surgical finding. Always brain very relaxed, so not swelling in all case. Thank you.
Thank you, Professor.
I have one more question, Professor Goto.
Yes.
Since we have you, it's not easy usually to get you. That's why I'm asking you this. Would you advise this for a microvascular decompression of trigeminal neuralgia?
Yes. Of course, many doctors perform the microvascular decompression through the lateral suboccipital keyhole endoscopic approach. Of course, this is a very useful procedure. So I think it's enough to just perform the microvascular decompression. Anterior keyhole transpetrosal too much to the trigeminal neuralgia. This is my impression.
Okay.
Goto Sensei,
Yes.
can I? Thank you very much for a great the talk, as always. So it seems a bit dark with your surgical area with endoscope. So can you adjust more illumination? I don't know. Maybe that you can see very clearly with endoscope. Just let us know, please.
Thank you. In case of the tumor surgery, especially the meningioma or trigeminal schwannoma, sometimes the tumor shows some bleeding, so the surgical field a bit bloody. Because actually, if we observe this surgical field microscope, it's not bloody, but endoscope is very close to the region. So sometimes a bit more bloody, like compare the microscopic view, but usually we not encountered the bleeding. So usually surgical field itself will very clear. Thank you.
Thank you so much. Thank you.
Professor Goto, there is a question in the Q&A for you. Dear Professor, do you usually check the venous flow before surgery to determine if you can sacrifice the superior petrosal sinus?
Of course, always we check the venous structure. To plan the skull-base approach to evaluate the venous structure is a key point to get good result. Thank you.
Thank you, Professor.
I think that's an important point because there are some variations in which the temporal lobe veins can drain directly into the superior petrosal sinus. In those cases, we should be very careful.
Yes.
Thank you. Thank you, Professor, for a nice lecture. We probably can try again. Dr. Ben or Professor Yang is here. He also got a copy of the video. You want to play again Professor 𝑠𝑢𝑔𝑎𝑤𝑎𝑟𝑎 video? Ben or Professor Yang?
Yes, I will try. Check that seems to be working. So, Leo, can I start?
Yes, please.
Can you see this? Can you see the screen, Leo?
Yes.
Good evening, everyone. I'm 𝑇𝑎𝑘𝑒𝑜 𝐺𝑜𝑡𝑜. Today, I'm going to talk about the surgical strategies and the techniques for cavernous sinus lesions. Nothing to disclose. Surgery for the lesion in and around the cavernous sinus involves risk of cranial nerve injury, especially for the tumor invading cavernous sinus. Therefore, radical treatment of such lesion is still challenging. In this presentation, I show the surgical strategies and techniques for such lesions with intraoperative video.
I think we're having the same problem.
Virtual resection may be indicated for the patient with neurological symptoms or tumor rapid growth.
So
with
this
no resection and preserve cranial nerve function and internal carotid artery. So we usually do the resection as much as possible, followed by the observation or radiation therapy. But this resection as much as possible all depends on the surgeon's skills and experience. So for some neurosurgeon, this means no resection, and also for some neurosurgeon, this means a gross total resection. Here is the SRS result for cavernous sinus meningioma cases. Rate is about 80 to 90% for news. I think it's good.
Ben, I think we're experiencing the same problem.
Yeah. So maybe Dr. Yang, can you try to see if you could share the screen? I will stop my sharing.
Okay.
For the tumor invading the cavernous sinus.
So Dr. Lee, maybe we can accommodate Professor Sugawa video. Can be the last one, I think.
Sure. We move to the last one.
Yeah.
Now we move on to the next speaker. It gives me a great honor to invite Professor Kelvin Mark, who is the Deputy Chief of Service and Consultant Neurosurgeon at Queen Elizabeth Hospital, Hong Kong, who is also a Clinical Associate Professor Honorary of Department of Surgery, the Chinese University of Hong Kong, and also the Vice President of Hong Kong Neurosurgical Society and first Vice President of Hong Kong Neuro-Oncology Society. His topic of the lecture today is on endoscopic transorbital surgery. Let's welcome Professor Kelvin Mark. Professor, please.
Thank you, Dr. Liu and Professor 𝑘𝑒𝑜 for the kind invitation again. Let me share my screen. Can you see my screen?
Yes, Professor.
Okay. So my topic today it's on endoscopic transorbital surgery. I presented actually a few times on the ACNS webinar, and I think it's time to have a slight change of the topic. So it's more about more advanced applications and multi-port applications, and to share our experience in Hong Kong. For the transorbital surgery, I think after these few years, some of us have been talking about it quite frequently, so maybe you have a concept already. To recap in short, so orbit is a window to the skull base. So to neurosurgeons, we all know that the orbit is a very important structure for craniotomy and skull base approaches, like orbital-hypomedic approaches. But on the other hand, the orbit can actually serve as a corridor. This diagram shows that like behind the orbit, there will be the anterior cranial fossa, the middle cranial fossa, and below will be the infratemporal fossa and the pterygopalatine fossa. So the yellow arrow is the direction for the craniotomy, which with reference to the cavernous sinus and carotid artery, it's essentially a posterolateral approach. So we have the medial approaches, that is via the endoscopic endonasal approach. We can do extended approaches by a transpterygoid approach or even mobilizing the cavernous sinus and carotid artery. But that would means that we need to cross the neurovascular structures in order to reach lesions lateral to the cavernous sinus. So the blue arrows would be a more direct and interior approach with endoscopic transorbital routes to handle lesions at the lateral part of the cavernous sinus. So there are a few names in the literature, endoscopic transorbital approach or tones. They're similar. They might in detail they might be a little bit different, but essentially they're similar if you look up the literature. And when compared to the EEA, endoscopic endonasal approach, the risk of CSF leak is very low because it does not traverse the paranasal sinuses, and that would cause a very low chance of CSF leak, and that's a superior advantage. And of course, it has a good cosmetic outcome, which I'll show you some of the pictures afterwards. So many people actually start to ask me how I started. So I decided to add in this slide. So I started off in 2018 when I was a fellow with Professor Sebastian Froelich at the 𝑇𝑎𝑘𝑒𝑜 Hospital, where I started off with dissection. So I learned from cadaveric dissection, and then when I went back to Hong Kong, I started the first case together with the ophthalmology colleague of our hospital, who was very experienced oculoplastic surgeon. So we started our first case as a temporal meningioma. And then fast forward 2023, last year, we have gathered our experience and published a book on this transorbital disease together with periorbital skull-base disease. And this year we have accumulated over 50 cases. And of course, thank you, Ben, who has been helping me a lot on this surgery as well. So this is my team. I work together a lot with ophthalmologists, ENT, and other skull-based teams as well. So this is a lab from my hospital, Queen Elizabeth Hospital. We have 5 stations here, and we'll be hosting some workshops in the coming future. So stay tuned and welcome to approach me or Ben if you're interested to come and join the fellowship. So, and also got the privilege to travel a lot in China these 2 years. There's growing interest in ETOA in the Chinese community. And of course, internationally, skull-based and even non-skull-based surgeons are getting very excited about this new technique. So these are the clinical cases that we have done, 55 cases. Most of them, we do it via a lateral approach using a lid crease incision or a subbrow incision. And in the beginning, we started with benign pathologies, and afterwards with more complicated applications like multiportal applications for malignant tumors that require en bloc resection with margins. So basic indications, lesions at the orbit, lesions at the sphenoid wing, classically with sphenoorbital meningiomas, lateral cavernous sinus tumors like trigeminal schwannomas, or frontal sinus pathologies like mucocele would be a good fit. So this is a case of an orbital tumor that is presented with optic nerve compression with a decrease in the vision. So we use a lateral approach to remove the orbital rim as well. And we put in an endoscope, we put in a 0-degree endoscope, and here is the meningo-orbital band that we identify and divide. And then we strip the periorbita away from the sphenoid ridge. So we also drill the greater wing of sphenoid to create more working space. And then we open up the periorbita with a knife and protect the periorbita with a malleable retractor. So for this case, we inject ICG to enhance the chance of identifying the tumor easily. Otherwise, under white light, it would be quite difficult to differentiate whether it is the rectus muscle or it is the tumor itself. So the cavernous hemangioma has a property of a delayed venous filling, just like in contrast MRI. And we're able to do an en bloc dissection of the tumor circumferentially and protecting and preserving the nerves and have a complete removal of the tumor. So post-op, the patient has a good cosmetic outcome. Here is another case, sphenoorbital meningioma. It's a recurrent case with a hyperostosis presented with a diplopia. So the main aim is to remove the area of the hyperostosis and to remove the tumor as well. So we also usually use the electromagnetic navigation system by Medtronic, which is a good system to localize the area where we need to drill or to localize deep-seated lesions. Again, we drill the lateral orbital wall with high-speed diamond burr. Sometimes now I switch to cutting burr because it is faster, and it's actually quite safe to do that with appropriate protection of the periorbita. And of course, the drilling of the bone, diseased bone, I would then switch to diamond burr. Otherwise, there can be quite a lot of bone bleeding. And so we continue the drilling with the diamond burr with irrigation and expose to temporal dura, and finally drill the remaining diseased bone. This is another case of a trigeminal schwannoma at the lateral wall of the cavernous sinus. Multiple ways can tackle this lesion, including endonasal approach or middle fossa approach. So we choose to use an endoscopic transorbital approach. So just notice how we do the blunt dissection to split the periorbita away from the temporal dura. And then we open the anterior capsule and then do a tumor debulking and removal. So with the interest of time, I just show the final view. So this is the pulsating CSF, and that's Meckel's cave. Just repair the dura defect with DuraGen and tissue glue. Patient has a much improved abducens palsy, which he had pre-op, and the numbness, which was the chief complaint, which was resolved as well. So for advanced indications, include lesions at the brainstem. This is a case of a craniopharyngioma, which I did a transorbital approach to remove the tumor and for brainstem decompression. There are some groups start to use an endoscopic transorbital approach for intrinsic temporal lobe tumors, and also have a case of reports for mesiotemporal sclerosis for epilepsy surgery as well. So other indications also include lesions at infratemporal fossa and head and neck tumors, which we use multiportal endoscopic approach. So this is a case of an illustration. We use a biportal approach combined with an endoscopic transorbital and endonasal approach. So this just show the part from the orbit. So we drill the middle fossa floor and identify the V3. And then because the V3 is deceased, infiltrated by a tumor, it's a sarcoma, biopsy proven, so we sacrifice the V3. And then the next step, which is crucial for this surgery, because it is a sarcoma, so we need to do an en-bloc resection with a margin. So you see the pulsatile structure there was the petrous carotid, which was then protected and identified from the transorbital route. So the other team can proceed with the excision of the tumor from below, while the transorbital team can protect the carotid artery and push the tumor anteriorly for an en-bloc resection. So in the end, the reconstruction was done using a nasoseptal flap. This is a transorbital route to pull the flap up to reduce the risk of ascending infection. So post-op, you see the extent of resection is adequate, and the patient was followed up without recurrence. So just skip through this, and these are the photos of my patients, which cosmetically are very nice. Can hardly tell which side is the operated side. So in summary, the ETOA is a direct anterior approach to the orbital apex and skull-based pathologies, especially lateral to the cavernous sinus and at the infratemporal fossa. Collaboration among neurosurgeons, ophthalmologists, and ENT surgeons would enable MIS multiportal surgeries with better patient outcome and shorter hospital stay. How to start training and cadaveric dissection in the lab is essential. We're holding a course at our lab in January in Hong Kong, 3rd and 4th January. It's a hands-on course, although the hands-on quota is full already, but observership is still open. So if you're interested, you can feel free to email me. And a final advertisement, we're going to hold an international endoscopic transorbital society meeting in November in Hong Kong. We're expecting more than 100 of participants, and we also will have hands-on course as well. So stay tuned, and thank you.
Yes, Professor Roy.
Yeah, thank you, Professor Mak. It was a brilliant presentation. I was very happy to see the advanced indications, especially the ones with the multiportal access. There's a lot of interest in this specialty in Europe as well. There are several groups working on it. In the next conference, we are hoping to have a hands-on course as well as part of the EANS skull base and the Frontiers Committee. So congratulations, and I'm looking forward to more of your work coming out.
Thank you.
Dr. Biswas, a question? You are
Sorry, I
muted.
cannot hear you.
Please unmute yourself, please.
Hear me now?
Yes.
Yes.
Yep. It's totally a new presentation for me. Just I wanted to know, do you use the endoscope holder
No, I don't use
when
endoscope
you
holder.
approach?
No, I don't use endoscope
It's
holder.
okay. And is there any ergonomical problem during drilling? I mean, with the periorbital orbital content and with the drill, when you go deeper into the orbit, and during drilling, is there any ergonomical problem with the content of the orbit?
Okay. So for the drilling, for the initial part of the drilling is actually more difficult, because as you can imagine, we need to create space. So it's different from endonasal approach. Endonasal approach, we just put the instruments in the nostrils, which the nostrils have a large space. So it's just like an ice cream cone. So the wider outside, the narrower inside. But the orbit is somehow different. It's a reversed ice cream cone. So outside is very narrow, so we need to be very cautious to protect the periorbita during the drilling. But deep inside, because what I didn't mention is that I drill laterally first. I drill towards the temporalis muscle, because there's nothing to fear there, and the space that we created, that would be the triangle region of the sphenoid ridge. And then with that, we can enjoy a larger space, larger and larger when we're going deep inside. I use the chopsticks technique. I'm not sure if you have heard about that. I trained with Sebastian, and so I hold the endoscope and the suction by my left hand, with my left hand, and the drill with my right hand. And usually I do it like this, but sometimes when I need meticulous bimanual dissection, I will ask my co-surgeon, Ben, usually, to hold the scope and do the dissection. Or sometimes I hold the scope for him and he does the dissection.
Okay. And just one more question. What are the complications you have faced in the early post-operative period?
Yes, very good question. So we do have complications, especially for orbital lesions, like orbital apex tumors, orbital apex vascular malformations. There would be a transient ptosis, and there are a few cases of transient visual loss, visual deterioration as well, not to the extent of loss, but deterioration, because these are very the baseline, the vision is very bad already. But with time, with steroids, most of them, they recover, and some of them even better than pre-op. And the recovery period is around 2 to 4 weeks, usually. We also have 2 cases of ascending infection for multiportal applications. So that's why I now, when we do it, I use the nasal septal flap to divide these 2 compartments. Otherwise, there would be a risk of ascending infection from the nostrils up to the orbit and being trapped there.
Okay. Well, thank you, Sensei. Excellent presentation.
Thanks. Maybe one question from me, Professor Kelvin. May I know that to open the optic canal, how easy and how difficult is it? Is it possible from the approach? Thank you.
Yes, it is indeed possible. That it is actually easier than thought. If actually, I'm not sure if I can share the screen again. I can quickly show you.
Share the screen.
Yes, can you see my screen?
Yes.
Yes.
So this is a case of we do an anterior craniolectomy as well via the transorbital route. So just want to skip through the MOB and we go superior. So instead of just removing the temporal bone, we remove the frontal bone as well, the splenoid. And this is the anterior cranial process that we removed. So here is after removal, and here you see laterally, this is the optic canal. So here is the optic canal. And here is the anterior craniolectomy. And it can be decompressed in a 270 degrees with the optic canal here. And this is the it's a pneumatized anterior canal, so we put in some fat as well to seal it off. Yep.
Thank you,
So
Professor.
it can be done.
Yeah, thank you. If there's no further question, we thank Professor Kelvin for his excellent talk, and hopefully more neurosurgeons can now learn from Professor regarding this approach. Let us move on to the next speaker. If we it give me a great honor to call upon Professor Yang Wei-Shun, who is the assistant professor. Oh, sorry, we have Professor Stanford here. Professor Stanford, are you here? Not sure.
She's here in the guest list. Stanford?
Oh, yes, guest list. I didn't see anyone. I just invited one professor in.
徐教授你在吗？
Yes,
Okay,
I'm
okay,
here.
I saw you. Okay, sorry. Let's move on to Professor Sanford Shu, who is the director of the Department of Neurosurgery, Taiping Veteran General Hospital, Taipei City, Taiwan, who will speak to us on cavernous sinus surgery step by step. Let's welcome Professor Sanford. Professor, please. You may
Yes,
start.
thank you. So, did you see my screen now?
Yes.
Not yet. You can.
Not yet.
Not yet. Okay, did you see my screen now?
Yes.
Okay, I would like to thank Professor Okokado and all the colleagues inviting me to join this great educational seminar. Today, I would like to talk about the cavernous sinus surgery. And I'm from Taipei Veteran General Hospital, and I learned all the techniques and concepts from my mentor, Professor Yazagil, and Dr. Krish, and Dr. Amafti. And because of time, I get started to the anatomy of the cavernous sinus. As you know, the cavernous sinus sitting by side of the paracellular region actually is a complex venous channels with complex neurovascular structure penetrating the dura into such a venous channel. And to do the cavernous sinus surgery, actually, at least 2 decades ago, the cavernous sinus was deemed as no man's area. But
We don't
since
have the screen.
gathering, no screen?
No.
Can you share it again for the PowerPoint? Yeah, we don't see the
Yeah, okay.
PowerPoint.
We have it.
Yes.
Now.
Yes, okay. So from now on, because of the familiarity with the anatomy of the cavernous sinus and the advancements of the microsurgical techniques, nowadays we can deal with the pathology in and around the cavernous sinus. If you do the microsurgical approach to the cavernous sinus, different from the endoscopy approach, you are confronted with 3 walls of the cavernous sinus. superior wall, lateral wall, and posterior wall. And actually, when I do the dissection in the lab, I always did the similar steps when I did the real steps in the OR. So you have to apply your knowledge to your surgical routine. I always using the pretemporal extradural approach to the cavernous sinus. So in such a surgical photo, as you can see, this is the optic canal, and following remove all the anterior clinoid. And you can see the whole lateral wall of the cavernous sinus was fully exposed. So you can see this is the trochlear nerve, this is V1, V2, and V3. So based on the concept and techniques from Professor Dolenc, the pioneer of cavernous sinus surgeon, we have to find some important landmark while you're doing the cavernous sinus surgery. For example, in the dural anatomy, you have to know the outer ring, tentorium. So when you remove the outer ring, it means that you can free the carotid artery. If you cut the ligament, you can free the optic nerve at the beginning of the surgery. And even for the bone anatomy, you have to know the anterior clinal process, and you have to know how to remove it. And also all these vital neurovascular structures, and you have to know where when they penetrate the dura into the cavernous sinus. And also you can see these black blocks is the basic approach to the cavernous sinus. It means that you have to know how to peel the dura off the lateral wall of cavernous sinus, and you have to know how to remove the anterior clinoid and remove the outer ring. In such approach, you can deal some simple pathologies. And based on this approach, with modification, you can do some transmicroscopic approach for trigeminal schwannoma or some other approach for some different pathologies. So you can see this table, you can do different approaches to different pathology, including vascular lesion. So based on my experience, I classify the learning curve of the cavernous sinus surgery into 4 levels. For level 1, if you have the ophthalmic aneurysm case or the tuberculous cellular meningioma or some intraorbital tumor, you have to know how to peeling the cavernous sinus, remove the clinoid, cutting the dura ring to free the carotid optic nerve, so you can deal with such kind of pathologies. And at the level 2, it means that you have to expose and open the lateral wall of cavernous sinus. The lateral wall of cavernous sinus is composed of the different triangles and the macroscape. In such cases, you can deal with the paraclinal aneurysm, some clinal meningioma to achieve Simpson grade 1 resection, and some types of trigeminal schwannoma. And if you get more experience, you can do the cavernous sinus surgery at the level 3. It means that you have to expose and open the posterior wall of the cavernous sinus. The posterior wall of the cavernous sinus composes the oculomotor window and the trigeminal orifice underneath the tentorium. So if you know how to open that, you can deal with the basilar apex aneurysm and all kinds of the trigeminal schwannoma and some invasive pituitary macroadenoma and ventral brainstem lesions. And the most challenging one is the petrocleval meningioma or some chordoma or cavernous sinus meningiomas. So you have to be equipped with the techniques that you have to fully open the cavernous sinus combined with the so-called Kawase approach, so you can fully unlocking the space from suprasellar, sellar, interpeduncular, prepontine to the posterior fossa. So, but the most important concept for cavernous sinus surgery is that all the vital neurovascular structure, when penetrating the dura into the cavernous sinus, they are anchored to this dura ring. So you have to free all of them from this dura ring for 2 purposes. One is widen the space between the nerves. The other one is minimize the traction on all these important structures. So I would show some example at each level. For level 1, like I said, you have to peel off the dura, remove the anterior clinoid and cutting the dorsal dural ring. So you can deal with such kind of cases. This is an ophthalmic aneurysm. This is pre-op, post-op. So when I do the peeling and I cutting the dura along the cilium fissure down to the base, and they stand in the incision towards the optic nerve and towards the tentorial incisura, so I can expose the carotid and the optic nerve. Then I have to cut in the phosphor ligament to free the optic nerve, and I have to remove the outer ring at the dorsal aspect of the carotid, so I can fully expose the neck region of the aneurysm. Then, as you can see, when you remove the ring of the carotid, so now you get the proximal control in the clinoid portion, and clipping the aneurysm becomes the most easiest steps during the aneurysm clipping procedure. The other example is tubercular cellular meningioma. It's the same steps. So when you can expose in this region, so as you can see, the tumor pushed the optic nerve against the phosphor ligament. So when you cut in the phosphor ligament to free the optic nerve, then you can see the indentation caused by the tumor. So when you do the tumor debulking or remove the tumor, it becomes safe at the beginning of the surgery because you already free the nerve and minimize the traction on the optic nerve. And at a level 2, the most common situation is such kind of aneurysm, is complex paraclinoid aneurysm. At a level 2, because you already know the lateral wall of the cavernous sinus, now you already, you can open the Parkinson triangle to get a proximal control, like this surgical photo show. I open the Parkinson, I localize the carotid, so I have the proximal control. Then I can get a proximal and distal control to trap the aneurysm. I straighten down the aneurysm to smaller size to facilitate the clip shaping of the aneurysm. So I can preserve all the perforators in such kind of exposure. And also at the level 2, the common situation is the such kind of the trigeminal schwannoma. This surgical photo shows that when I'm peeling the dura off the lateral wall, I can localize the Gesserian ganglion and the macroscape. Then I need to cut the tentorial dura at the base so that I can track the temporal pole to expose the tentorium. So I open the macroscape and I cut in the tentorium so I can localize the whole course of the trigeminal nerve from the periphery down to the brainstem, down to its SE zone. So I can trace all the course of the trigeminal nerve. So in such kind of approach, I can deal with different kinds of trigeminal schwannoma. For example, I'm peeling off the dura off the lateral wall, so the tumor is bulging out from the macroscape, and you can open the macroscape, then removal of such kind of tumor actually behaves like you remove the convexity meningioma. You debulk the tumor, you found a plane between the nerve and the tumor capsule, and you follow the nerve. Like this picture show, I cut in the tentorium to widen the exposure, then I following the nerve down to the brainstem and totally remove the tumor. And also this kind of case, when you know how to open the posterior wall for such kind of case, the basilar epic aneurysm, usually you need to mobilize the oculomotor nerve. So you have to open the oculomotor window in the posterior wall of the cavernous sinus. So as you can see, I open the dura down to the base and I cut in the tentorium incisura to expose the orifice of the oculomotor nerve entering the cavernous sinus. I free the oculomotor nerve. Then I also need to remove the posterior clinoid because it is in the way to the basilar trunk. If I mobilize the third nerve and remove the posterior clinoid, now as you can see, this is the basilar trunk. So I got the proximal control, and also I got the distal control. Then the same techniques, I can shrink down the aneurysm, and I can put the final clip. So another case is for the level 3 is invasive pituitary macroadenoma. It's the same. You fully exposing the little wall of the cavernous sinus. Usually the clinoid is already eroded by the tumor, so I can easily remove the clinoid to other parts in the superior wall of cavernous sinus, and I can exposing the clinoid portion of the carotid. And then I can open each window, but remember, like I said, you need to free all these nerves at the beginning from the dural ring. Then I remove the tumor in each corner. So I remove the tumor between the third and fourth nerve. Then you can localize the intracavernous carotid. Then next step is to identify the abductor nerve from the duodenal canals just underneath the V1. So I can tracing the course of the carotid into the cavernous sinus. Then I found each vital structures. Then I open the window between the V1 and V2, removing the tumor, exposing the intracavernous carotid. And also I turn the microscope to the supracellular region. As you can see, I free the carotid by cutting the outer ring and free the optic nerve by cutting the phospholigament. So I can remove the tumor within each windows. This is the post-op picture. So as you can see, I open each window between all these neurovascular structures. And as you can see, all these structures are free from the ring. And also at the level, when you get in the higher level at level 4, you can deal with the some basal trunk aneurysm or the petroclival meningioma. Like this case, this is a large VB junction aneurysm, and this is post-op DWI shows no signal, no more signal. So how I can do it? I fully open the cavernous sinus like this photo shows. I free all the nerves from the supracellular region and combine with Kawase so I can exposing the posterior fossa. So as you can see, this is the right side, left side vertebral artery, and the VB junction is just underneath the fifth nerve, and the aneurysm is just underneath the tracheal nerve. So as you can see, this is the aneurysm, just underneath the tracheal nerve, and all the nerves are free from the dural ring. So since I opened the posterior fossa by remove the anterior petrous bone, so I got the proximal control. I already have the distal control. So I can trap the aneurysm and using coagulation to shrink down the aneurysm. Then I can do the final clipping the aneurysm. And also the intracavernous aneurysm, I skipped this case because similar techniques. Fully open the cavernous sinus and open the Parkinson triangle, have the proximal control and distal control, and I coagulate the aneurysm and do the final clipping. I skip because of time. And the most challenging one is petroclival meningioma. If you have the level 4 experience, you can deal with such kind of cases. For example, these cases, this pre-op, post-op, post-op, it's the same. You have to fully exposing the cavernous sinus, so you have to remove the anterior clinoid to exposing the optic canal. And also you have to remove the anterior petrous. Now you have to free all the nerves at the beginning. So you cut the phospholigament to free the optic nerve, and free the third nerve, free the tracheal nerve. Then you remove the tumor within each windows. And you can open the microscope to remove the tumor so that you can exposing the trigeminal rootlets. And the same techniques, you follow the trigeminal nerve, cutting the tentorium, so you can follow the nerve down to the brainstem. And also you have to preserve the tracheal nerve. Then you remove the tumor within the cavernous sinus. Similar techniques in the macroadenoma. You have to find the important ligament, the petroclival ligament, because the duodenal canal, the sixth nerve is coming inside the ligament. So as you can see, this is the sixth nerve, the groupal ligament. So anything outside the ligament, when you remove them, is safe. But within the ligament, you have to be careful because the sixth nerve. So this is the post-op photos. I remove all the tumors and free all the nerves from the dural ring. So we just published our experience in Journal of Neurosurgery last year. And this is the final slide. I always remember that Professor Yasuko told me the assertion that the complete elimination of the brain tumor will carry the risk of significant mobility and mortality actually neglects to consider the facts of the surgeon's competency. So as a neurosurgeon, we need to get our experience in the lab at the beginning, then you apply your knowledge of anatomy to your patients. Only in this way, your patient benefits from your surgical, even the surgical techniques or knowledge. And thank you very much. Any question?
Professor Roy?
Yeah, thank you very much. That was a fantastic presentation. Congratulations on your work, and your surgical competence to achieve this kind of thing is not easy. I know that from personal experience, and congratulations. I was very impressed with the approaches that you are able to do and how meticulous you are with the technique.
Thank you.
Dr. Ben?
Yeah, and first of all, I'd like to say hi and thank you for Stanford, and thank you so much for your teaching us again about the cavernous sinus. And personally, I learned so much from you, and thank you for that. I have a question about the approach for the basilar aneurysms. So you could approach it about combined with anterior pudicectomy, but sometimes you could also above below with the far lateral approach. For example, that like the VB junction aneurysm that you encounter. So so the first thing is that the first question is that how would you choose whether you approach above or approach it below? My second question is about the mobilization of the third nerve. So how often do you see that is necessary to mobilize the third nerve for keeping the basilar aneurysms?
Yes, the first question is, of course, you have to study the images carefully about the level of the aneurysm. Most of the basilar apex aneurysm, if the aneurysm is higher than the clivoration, actually it means that you have to go below. You're looking from below upward. So it means that you have to cut in the zygoma to lower the temporalis muscle, and so that you have the direct angle, the vision of the projection to the lesion. And if the aneurysm lower, of course, it means that maybe you just can do the pretemporal approach, but you still need to cutting some part of the tentorium because you need to expose the oculomotor window and you need to free the oculomotor nerve. I always free the third nerve and remove the posterior clinal because I need get access to the basilar trunk because I need the proximal control. So I always free the oculomotor nerve. If you don't mobilize the oculomotor nerve, the window is very narrow and you may put too much stress on the nerve. That will causing some more longer time of recovery from the ptosis. If you free the third nerve at the beginning, then most of the people, even they have the ptosis, is transient and recover within 3 months. So the most important is decide the level of the aneurysm. So the case I show the VB junction, if you know the different exposing corresponding to different area. For example, when you're removing the superior wall of the cavernous sinus, actually it corresponds to the suprasellar interpeduncular fossa region. If you know how to open the lateral wall of the cavernous sinus and cutting the tentorium, actually you can get access to the preponderant space and the lesions surrounding the upper clinal region. And if you combine with the Kawase approach, then you can do the pathology more lower, even in the posterior fossa. So at each, with the different levels, the exposing area is from suprasellar down to the all the way down to the posterior fossa. Yeah.
Thank you so much, Stanford, and congratulations on your success and also the coming Congress in Taiwan. Congratulations.
Thank you
so much.
Thank you. Looking forward to seeing you again.
Thank you.
Thank you. Thank you, Professor Sanford.
Thank
Probably one short question from me, Professor. There's many paper, especially from Ali Chris group, propose on how to tame the cavernous sinus by using a fibrin glue, but there are some opponent to it. They think it's unnecessary and dangerous. What is your opinion regarding this?
Yeah, you mean the tissue glue? Usually,
yes.
I do the hemostasis while doing the cavernous sinus surgery. I'm using a lot of tissue glue and some other hemostatic agents. But for the tissue glue, I inject the tissue in between the V1 and V2. And sometimes when I remove the clinoid, I will open the membrane surrounding the carotid so that I can get access into the space of the cavernous sinus. So I will inject the tissue into the clinoid portion of the cavernous sinus. Then you inject the tissue, remember there's a sphenoparietal vein. So I'm using the sucker to compress the sphenoparietal vein to prevent the tissue going backwards into the sylvian vein, especially when the deep sylvian vein was blocked, occluded by the tissue, the patient will suffer from the temporal lobe swelling after the surgery. I have 2 to 3 cases after the surgery. The patient had a swollen temporal lobe, and especially on the left side, the patient developed aphasia. Usually it's resolved within 2 weeks, but people don't like such a situation to occur. So you need to compress the sphenoparietal vein when you inject the tissue. Also, we're using other hemostasis agent like a spongostan. It's kind of the gel foam powder. The gel foam powder is good for some oozing. You just compress the gel foam powder overlying the little wall of cavernous sinus, and actually you will minimize the oozing from the wall of the cavernous sinus. And also, the tissue can be used for the bleeding from the bone, the cancerous bone. You inject the tissue into the bone marrow, so it stops the bleeding from the bone quickly. So this is very useful for the tissue. Yeah.
Thank you, Professor. Thank you for your excellent presentation. I think there's no further question in the Q&A box. We will proceed to the next speaker. It gives me a great honor to invite Professor Yang Wei-Shun, who is the Assistant Professor, Department of Neurosurgery, New Taiping Municipal Tun Cheng Hospital at the New Taipei City, Taiwan. And his topic of presentation today is on the technique of extradural anterior clinoidectomy. Let us welcome Professor Yang. Professor, please. You are muted, Professor. Professor, you are still muted. Your mic is not on.
Yeah, is it good?
Yes, we can hear you now.
Oh, thank you. So, thank you for inviting me to join this event. It's my great honor. And this topic is about extradural clinoidectomy. It's more like a basic lecture. So, my name is Wei-Shun Yang. So, if everyone has any question to ask, you can find me on like Facebook, Instagram, like that. I have nothing to disclosure. This is my hospital work now. So I'm very happy. I have to thank to my mentors. First one is Professor Leclerc, because I have studied in NI for years. I really learned not only technique, but also like mentally a lot from Professor Krish. second teacher is Tanikawa Sensei. I learned a lot of knowledge about vascular management from him. And also I have to thank to my good friend and teachers. First is Professor Sensor, because he support me a lot, especially support me to learn from Professor Krish. Another one is Dr. Takashi Sugawara. So here's my reference. You can, if any you like to know, you can read the book, Wharton book, the length book, and the paper from Professor Krish. So why we have to remove the anterior carotid process? Because we have to widen our exposure in some cases. And another point is after SCP removal, we can see a lot of nearby neural structures such as ICA, cranial nerves. So this is an example. We can tell that if you remove the ACP, the gray triangle area, we can see that like carotid segment of ICA, optic nerve, third nerve, like that. But before we do the surgery, there are something we have to prepare, such as our anatomic knowledge. So maybe we have to learn from the cadaver course. Another thing is we have to prepare the micro instruments such as micro knife, micro scissor, or even micro launcher, and as small as possible the pearl tip, including cutting burr and diamond burr. In our hospital, we have a smallest pearl tip is 1 millimeter, and of course the material to achieve in the state places. But not sometimes I will be asked about how we choose between extradural approach or intradural approach. In my opinion, I prefer to do extradural approach to remove the ACP because in most of cases, extradural part, usually we have normal anatomy. Those most of the lesion fit in the intradural area space. So we don't have to major lesion in the beginning of the surgery. Then while doing the extradural work, we can have more comprehensive understanding of the nearby structures. But some surgeons said that they using intradural carotidectomy, they can save a lot of time. They can see the lesion early to prevent the injury of the lesion, such as aneurysm. That's fine. I think it's better to know both of this. But why I like to use extradural carotidectomy? Some surgeons might ask that while doing the extradural work, we may put too much pressure on the temporal. But actually, when we do the extradural part, even we use like a retractor, but because the brain is covered wholly by the dura, so the pressure force was distributed widely. So in my experience, I seldom have a patient suffered from the temporal traction injury. But of course, in certain cases, if the patient has severe brain swelling, we can, while doing the extradural work, we can make a small hole on the both of the optic nerve, so we can release some CSF from the optic disc to relax brain. Another question is, does it take too much time? But it depends on the familiarity. So if you know the anatomy well, I think it will not take too much time. Besides, after doing the extra job, then we have a wide operative field. At that time, it's very fast to deal with the lesion. So here are the steps about the skin incision and craniotomy. Usually I will do it as much low as possible. It's better to see the temporal base, because in the later on we have to do the skin sinus split. Then I will try to give patient maybe some diuretics to release the blood. Then drill the sphenoid ridge. This means the laser wing. Then I will remove part of the orbital roof and the lateral orbital wall in order to know the location of the active canal and the superior orbital fissure. Then cut the middle orbital band. And then I started to peeling the cavernous sinus outer layer from SOA. Maybe I will, it depends on the lesion, but usually I will expose the third nerve, fourth nerve, V1 and V2 to have a better view of the ACP. Then I will try to dissection around the ACP, disconnect the ACP from the laser wing and the optic straw. The final step, of course, is to remove the ACP. But in this step, we must take care. Do not try to force or break it. Instead, we better to drill out most of the ACP, then gently deliver it out. So from this picture, we know that the ACP connect to the laser wing and optic straw. So after we drill the core of ACP, make dissection around 180 degrees of ACP, then carefully remove the connection with laser wing and the optic straw. So here is the video I can show you. Can you see the video?
No problem. No.
No? So let me change.
You could share the video instead.
Sorry about that. Yeah. Can you see the video now? Is it good? The surgical videos. Okay. So here we can see that I drill most of the part of the temporal bone, so I can see the temporal bone very clear. And sometimes I use. Yeah. Excuse me.
But we haven't seen the video.
Oh, not you. Let's see the video. Follow. Yeah, is it good?
Okay, now can.
Okay.
Yeah.
Okay. So I usually will remove part of the orbital roof. Then the reason to do this because I need to know where is the optic canal, and the optic straw is next to the optic canal. So and then I will start to split the cavernous sinus, because I will split the canal sinus until I see the third nerve, fourth nerve, V1 and V2 to have wider surgical view. And then, and usually in the beginning, it's very difficult to split the canal sinus, but if you find out the right plan, the process will become faster and faster. So here is the V2 and the V3. So until now, we can see that the canal sinus and anterior canal process become gradually more clear. Okay. This is another case. I also take off uphill roof and of the wall. So when I know where is the optic canal, I will decompress it to expose all the optic nerve. So here we can see that optic nerve is almost exposed. So then I start to drill the anterior canal process. After remove inside the anterior canal process, excuse me. Yeah. I will use a micro longer to remove it small piece, but in this step, try not to break it. If where I think it's hard to remove, I will try to dissect ACP again to freeze it. When ACP become very small, it will very easy to take it out. So you can see that if you drill it a lot, it will very easy to take the ACP out. So yeah, so this is not very difficult to perform. Okay. So let's back to the point. Okay. So for the beginner, some surgeon might think it's very difficult to. I don't know where is the right trend to split the canal sinus. In my first case, when I try to do it, I will zoom in the microscope as much as possible to see the nerve fiber. But when you zoom in the microscope, you will find that nerve fiber. The right plan is that nerve fiber will be covered with a thin layer of dura. Another hint is if for beginners, it might be easier to split the canal sinus from V1 and V2. I think that that area is more easy to split the canal sinus. Another point is hemostasis. You can use usually I will use a fibrin glue, but sometimes I will also use Surgicel and geofoam. Sometimes I will be asked that should I expose until V2? I think for a beginner, it will be better to expose V2 because you have a better view of ACP. But if you have, after you gain the experience, it depends on the region. So for example, if we expose only like third nerve and fourth nerve, the ACP inside the green circle. So the view is very limited. But so if we split the camera size until the V2 or even V3, you can see the ACP very clear. Another question is that should I remove the optical roof or even like a lateral wall? Just like the answer of question 1, for a beginner, I think it's better to remove the optical roof and the lateral wall because I can know where is the optic channel, where is the optic nerve, where is the optic trough, and know the exactly the location of camera science posers. Here's the example. If I totally expose the periorbita, then I will know where is the optic nerve, and I know where is the superior optic fissure. So I don't have to worry about why injure the cranial nerve. So that it's for the beginner, I think it's better to remove all the bony part to see it clear. So that's the final slide. I also upload some surgical video on my YouTube channel. So not only the surgical video, but also some video will include the complication such as bleeding or rupture and so I welcome everyone to leave comment. Let's keep growing together. Thank you. Yeah.
Thank you, Professor Yang, for a very detailed lecture on clinoidectomy. Professor Roy? No, Professor Roy is not here. Probably I will start with one question. Professor Roy, yes, comment
Yes.
from you.
Yeah, thank you very much. I enjoyed your presentation of the anterior clinoidectomy. This is the key to unlocking the anterior cranial fossa. I'm glad you showed this for young neurosurgeons. It's very, very important. Thank you very much.
Thank you so much. Yeah.
Yeah, thank you. Maybe one question from me, Professor Yang, regarding
sir.
Extradural approach to anterior clinoidectomy. Do you
Yeah.
prefer to put lumbar drain as a for CSF diversion for safety? Thank you.
I honestly, I never use lumbar train when I do and anterior clinoidectomy because in case of a patient with very severe brain swelling at that time, I will, when I do the extradural working, I expose the optic nerve. So I make a small hole on both the optic nerves, a small hole on the dura. Then I can access to the optic carotid cistern. So I relieve the CSF from that cistern. So I never use lumbar drain in when I do ACP remove. Thank you.
Thank you, Professor.
Thank you.
Dr. Yang, thank you very much for your great talk. I
Thank
have
you.
one question.
Yes,
So
sir.
if the aneurysm, paraclinoid aneurysm, which is projecting the superior side, so which is better for the clinoidectomy, the extradural or intradural? And why?
Yeah. For aneurysm case, yeah, no matter what kind of position, usually I will start anterior clinoid using extradural approach. I know some in some cases maybe worry about do I injure the aneurysm while doing the clinoidectomy. So that's why in my slide, I will say when we do craniotomy, especially in the final step, try not to push the instrument too hard or push the bone too hard. Must be very gentle. Must be very gentle to avoid the injury. Yeah,
Okay. Thanks
thank
so
you.
much. Yeah.
Thank you.
I think the hybrid technique is becoming very popular for this particular indication. So many people are now doing part of the extradural clinoidectomy and then going intradurally and completing it, especially for aneurysms. It's becoming quite popular these days. The hybrid technique.
Hybrid technique. Maybe I sorry, but I don't have that kind of do you mean combine extradural and the intradural
Exactly,
approach?
exactly. So start with the extradural and the final part you remove intradurally. It's been reported, I think, in JNS or one American journal, and I've seen many people do that recently.
Thank you.
Yeah, but I don't know because I usually I will expose the usually I can have a wide surgical field. You can see that from my video. So I don't need to do extra work from intradural, you know.
Thank you, Professor Yang, for excellent.
Thank you.
We have Professor 𝑠𝑢𝑔𝑎𝑤𝑎𝑟𝑎 here with us. I'm not sure
Yeah.
whether he can. Professor, can you on your video, Professor? Oh, he's still at the airport.
I just arrived at the airport and I picked up my baggage.
Hi.
I'm very
Still in
sorry
there.
about making me
So
inconvenience.
where are you now, Sugawara Sensei? Where are you now?
Now I'm in the Taipei airport,
Taipei.
in the airport.
Mm,
And
The
so
Taipei
I'm sorry,
all
I
the
cannot
best.
talk a lot and giving a lecture here. I'm sorry.
So if your recorded video is not incomplete, so but maybe the next time
Ah,
you can show us the
okay.
complete one,
Oh,
please.
I really apologize about that.
Well, we missed you this time, but hopefully you can join us the next time, Professor Sugawara.
Okay. Thank you very much.
Okay. All the best at the Taiwan meeting.
Yes.
So I think Prof sorry our last speaker, Professor Massimiliano, I don't think he's around. So yeah, we probably call him again for our next session. Before we end the session, probably we will hear concluding remark from Professor Roy as the chair of the skull-based EANS section. Professor.
Yeah, thank you, Liu. Thank you for putting this very good program. The talks, 4 talks we heard were excellent. I learned a lot, and I'm sure the young people would have learned as well. Thank you for putting this together, Professor Yoko.
Thank you, Roy. So any message for young doctors about the training of the skull-based study? Just brief message.
Well, I think the key for young neurosurgeons is to spend as much time in the laboratory as possible. I know cadavers are expensive. It is difficult to acquire. Injected specimens are even more difficult. But any opportunity to work on a cadaver, I think, should be used. I think the new models with the 3D printed models can be used for basic neurosurgical training for less advanced people, and to keep the cadavers for the more advanced fellows and young faculty, so that they can refine their skills. And the key is to stay in the lab as much as possible and to keep going back to the lab. Even at my age, I keep going to the lab as much as I can, almost every week, so that it keeps improving as you go along and you listen to these talks from the very senior people.
Thanks so much.
Thank you, Professor Roy, again for your full support, always. Probably we also hear a concluding remark from Professor Yoko Kato before we close the session.
Okay, thank you so much. So unfortunately, we don't have enough the speakers today, which we planned. But I think the next year we have the inter meeting of the ACNS Bangladesh. Maybe I think May. Maybe we can have such a wonderful skill-based session. Maybe the lead by Dr. Roy. Dr. Roy, do you agree?
Yes, absolutely. Absolutely.
Yeah. Okay. Okay. Thanks. So maybe we can communicate by
Yes,
email.
absolutely. Looking forward to it, Yoko.
Yes. Yes. Thanks so much. Ben, today you're very silent. Please.
Oh, yeah.
Finally, you can make some
And
point.
yeah, and first of all, I'd like to thank you, Professor Yoko Kato, for making these ACNS, EANS webinars. And actually, for me, I'm first of all, I'd like to congratulate for the success of this meeting and also the success for the speakers on their respective specialties under the subspecialty of skull-based, and they're all teaching us a very important and very advanced techniques. And definitely we need to go for the training in the laboratory on models, or if possible cadavers. But also it's important that we keep listening to the experts' opinion about like how could we improve ourselves. And second point is that I'm so happy to see some of the teachers again. So some of them I meet them in person and learn a lot from them, and also I learn so much from them in these webinars. But yes, and I'm so happy to hear that we're going to have a chance to meet again in the future. Yes, and just now Dr. Roy said that we could possibly meet in Bangladesh. I think it's good that we keep that spirit to meet up and learn with the skull-based technique from the experts all around the world. And thank you so much.
Thanks. Maybe Dr. Atik, you are representative of the Bangladesh inter meeting.
Yeah, thank you, Professor. Hopefully, it will be a nice program as usual under your guidance. And I will keep communication with Professor Liu and with you regarding the faculties, and we will organize as per your suggestions. Thank you.
Thanks so much. Dr. Liu?
Yeah, thank you. Anyone else? If not, we will close the session officially, and hope we will meet in our third edition in Bangladesh. Thank you, and good night to everyone. Thank you.
Okay, good night.